Hi. Hello, welcome to Knock Knock Hi with the Glaucomfleckens. I am Dr. Glaucomflecken,
I am Lady Glaucomflecken.
and we are excited to have you here today. We're talking about something a little bit different today than we have in the past. Talking about IT,
Mm-hmm.
health IT,
Healthcare IT.
healthcare IT. A wide-ranging conversation about just where it's going, where it's been.
Mm-hmm. Why it's
Uh,
been where it's been and
yeah,
going where it's
we
going.
basically like throw our guests some like things that we want and like tell him to make it happen.
Yeah, it's a little bit like Christmas morning and asking, Santa Claus for
Exactly,
some things that we
exactly.
want.
And so, what it made me think about was actually the time that I spent as a super user for Epic.
Mm-hmm. I
Do you
remember
remember that?
that. Mm-hmm. I do.
So I was like I did it as a fourth year med student and a little bit as an intern
Yeah.
as well. I like all my vacation time went toward
Right.
going to mostly the Henry Ford health system.
Mm-hmm.
When they shout out to everybody at Henry Ford, um, when they went live with Epic, this was like
This
2013.
was pre Glaucomflecken, so there may have been
Yeah,
some people, some listeners out there who interacted with you and
maybe,
did not
maybe.
know it.
I got paid extra money obviously to like go and do this. That's the only reason I did it because it was the worst job ever, real bad. Because what I had to do was they put me in like some area of the hospital. So at Henry Ford, I was mostly in emergency medicine, and I had to walk around and like help people, like teach people how to do like discharge summaries and admission orders and all just put in anything, all like make smart phrases, all this stuff. So and and you can imagine like Henry Ford's a big health center, and so you can imagine people were stressed, and we were in emergency medicine
Yeah.
and learning how to use Epic, and so it was a high stress situation,
Mm-hmm.
and I do remember at one point during the week I was working with a cardiologist, and I think it was a cardiologist, and he was toward the end of his career,
Mm-hmm.
and that was it was the hardest for those individuals because they'd been on paper charts for like 30 plus years.
Right.
And all of a sudden here, the last few years of their career, they had to like switch over to the most complicated thing in the world, Epic. Very, very different experience.
And that's your electronic health record
Yeah.
system,
Yeah,
right? So
that's
when you
the
go to the doctor and the doctor's like typing into the computer, they're
typing.
likely
That's
using
Epic.
Epic or something like Epic.
Yeah, there's lots of them out there, but Epic's
Okay.
the one. So that's the one we were on. We were working on, and so I'm working with this doctor, and he's not saying anything, and I'm like walking him through how to do like I think it was a admission orders or something, and a- and as I'm sitting there like teaching him, he stands up and he just walks away, like he didn't say anything to me. And I was like, I didn't know what was going on, so I went on to do other things. He actually didn't come back that day, and so toward the end of the week, I asked someone about this guy. I was like, "Hey, I was helping this guy. I haven't seen him since. Like, what was going on?" And they told me he retired. He he
You were
decided,
the last straw.
yes, he decided that he would rather end his medical career than listen to me talk about discharge or admission orders for one more second. That was it. So that gives you a little flavor about what the Epic super user job was like. And so shout
Mhm.
out to all the Epic super users. You got a hard job, but thank
Do
you
they
for
still
what you
have
do.
those? Are people still doing
I
that?
mean, people are still going live. I mean,
Yeah.
I feel like everybody's on some kind of health record, electronic record system at this point. Actually, we learned 97%.
That's right. We
Yeah.
did learn that.
And so yeah, that's still out there. They're still
Yeah.
doing it. I don't know, maybe international. I don't know if it's still happening in the US, but
Yeah. I remember what I remember from that time is you coming home and expressing a lot of frustration about the triple clickers.
oh, triple clicking.
Yeah.
Yes. Lots of I mean, that's like a lot of the job was just sitting there watching someone try to like do something, right?
Right.
And a lot of you out there, you love to click 3 times on things like consecutively. It's my understanding, and I'm by no means a computer expert,
It's
that
true.
there's never a situation where you need to click 3 times consecutively on one thing.
In fact, it usually creates more confusion than
That's
anything
right.
else.
That's right. I was,
Then weird
that's
things start
funny.
to
It's funny
happen.
that you remember that.
Yeah,
Yeah.
oh yeah, I
I
do.
think I was having nightmares about triple clicking.
Yeah.
Anyway, let's get to our guest today.
Let's
So,
do it.
we have for our guest Dr. Micky Tripathi, and it's just fascinating guy. He's the national coordinator for health information technology at the U.S. Department of Health and Human Services, where he leads the formulation of the federal health IT strategy. This is like he's like the health IT
Yeah,
guy.
he's the nation's health IT man.
Yeah, it's like so if you have a question about like health IT, like
Fax him your suggestions.
facts. This is the guy, and it really was like it's just we had a fascinating conversation about all kinds of stuff. He answered all of my questions that I've had as a physician working in healthcare and medicine and
Yeah.
dealing with all these things. So
And he's a fun guy too. It was a fun
yeah,
conversation.
yeah.
He's got a good sense of humor
I don't
and
know what preconceived notions you all have about IT people. All right. But it was a very gregarious, wonderful individual. Not that they
he's not
aren't.
what you'd expect. He doesn't even like a basement.
That's right. That's
He
right.
gave us some stories about that.
Well, let's get to it. All
Let's
right.
do it.
Here is Dr. Micky Tripathi. All right, we are here with Dr. Tripathi, Micky Tripathi. How you doing, Micky?
I'm doing great. Really
Yeah,
look forward to talking to you.
thanks for joining us today. Now, I got to start with a question. How does someone become the world authority on like electronic health IT? Because it's not exactly something that a kindergartner will say that they want to do when they grow up. Like I just like how did you get to into this field? It's kind of fascinating to me.
Yeah, it's you're right. I didn't sort of pop out, especially, I'm old, so back then it would have been, amazing vision to say electronic medical records. That's where I want to be. Um, so I was working for a consulting firm, and we went out to Indianapolis to do some work with the Reagan Street Institute out there. I don't know if you know those folks, but they've, in Indianapolis, it turns out is like a beacon of health information technology, unbeknownst to a lot of people.
Hmm,
Really? Oh,
Yeah, and
who
there's
knew?
there's an
who would
there's
have
an
thought?
institute out there called the Reagan Street Institute, and founded by a guy who was an industrialist who went to a hospital, and was shocked by what he saw. Like he couldn't believe that,
Yeah.
that they were using better technology in dishwashers than they were using in hospitals. And so he created this
Fair enough.
institute that I think both of you will probably attest to that being the case. And so he created this institute that worked on health information technology. So anyway, I was working for a consulting
Yeah.
firm. We went out there, we did a bunch of market research, and we kind of looked at it and said, wow, this could be, like a really interesting business. This is like in
Yeah.
2002,
Yeah,
and
the
that's what
the
got me started in this area. And I just like love areas where you mix science, technology,
right.
policy, and business.
Hmm.
Well, you probably saw the landscape of health IT and realized, "Whoa, there's some work to be done here."
Yeah,
Yes,
it looked
it's
like it
a
was going to be
desert.
lifetime employment for the rest of
Yes.
my for the remaining part of my life. Yeah.
And I mean, because you've been at, I mean, just the change that you've seen over the last 20 plus years of going from paper records exclusively, pretty much, right,
Yep.
to just this really rapid adoption of electronic health records and different healthcare record systems and so how do you feel about the speed at which this has happened? Is it going fast enough? Is it too fast? Is it how are we doing just in general?
Yeah, my clinician friends will kill me for saying this, but I think it's going at the right pace.
Oh, okay,
um,
good,
which
good.
is to say that, if you and I know, I mean, you were on the front lines of, living this,
Hmm.
right, of this change. So actually I should ask the question back at you, but just to give you for the
Yeah,
context, we like in 2010 or 2005, whenever it was, something like 5% of providers were using electronic health records. And that was self reported. So that was also, my brother in law's Access database, Microsoft
yeah,
Word with macros. That's all electronic health records, right? And then we
right.
invested a ton of money through, federal incentives and the private sector, to the point that we're now at the point where 97% of hospitals and like 85% of ambulatory providers are using electronic health
Wow.
records. So that's like a short, probably 10 years. And if you think
Yeah.
about this is the like the most complex part of the biggest economy in the world. Flipping that from like pretty much
Mhm.
0% adoption or 5% adoption to 97% adoption in 10 years, that's a pretty remarkable achievement, I think.
There really is. And so what so was it the subsidies you're talking about? Was that what really started driving it? Like what was the impetus to like really turn the lever and, just really get it ramped up, do you think?
Yeah,
What
it
were the
was
factors there?
so the problem we had before the federal government, so the federal government dollars were huge.
Mhm.
It turned out to be about $35 billion in incentives through Medicare and Medicaid. You hopefully got one of those checks.
Yeah.
Like to make sure
Mhm.
that all of the really advanced physicians got them. But before then, the challenge was that there was like slow adoption of electronic health records. But
Right.
healthcare, as you know, healthcare is really complicated in our country, right?
Right.
And so the challenge from a technology perspective was that it was kind of a prisoner's dilemma. Like,
Mm.
doctors felt like, well, I don't want to, why should I invest in this technology? It's like $40,000 a user or whatever, but I get no benefit, right? You have no pricing power as a doctor. It's not like you can say, oh, I'm going to pass this on to my customers. Well, you can't charge anymore,
Right.
and the health insurer isn't going to pay you anymore. And the health insurers on the other side felt like, well, I don't want to provide, the subsidy for the electronic health record because I can't prevent that doctor from using it on patients who aren't my members, right? So they felt like,
Mhm.
well, I'm going to pay for the whole EHR, but I'm only 10% or 15% of that patient of that doctor's panel, and so therefore I can't capture all the benefits. So we're like at this real stalemate that everyone felt like, well, it's good for society, but not in my
Yeah.
interest to do it.
Mm.
So then the federal government came along in 2010, high tech, and said, well, there's a public goods problem here, and
Mhm.
also Medicare and Medicaid have a really distinct, kind of incentive to say, well, wait a minute, our providers are all across the country, and it would be great for them to adopt electronic medical records because we believe that's good for Medicare and Medicaid and good for patients at large. So, how about if we provide the incentives and kind of share the cost? And, in a way, it's not that different than businesses do every day. If you think about,
Right.
Ford and Toyota and Walmart, they invest in their supply chains. I know you don't like to think of yourself as a part of the supply chain, but but
Well,
sorry,
I no, I
sorry to
see it.
break it to you. For
No, that's
Medicare
a
and Medicaid, you're just supply chain.
I get it. Absolutely. Well, it's I remember so I when I came into medicine, so I started med school in 2008.
8.
And so this was very and we had it was like the hospital I was in, which is Dartmouth Hitchcock Medical Center. We had this kind of hybrid system. It was like the we had the some of it was on this I don't even remember what it was called. It
Yeah, they
was
had like a
very early.
homegrown. I forget what that was
Yeah, yeah,
called.
yeah,
Yeah.
yeah. CIS, something. I don't know. Anyway, I don't know what it is. But
Someone out there is yelling at
yeah,
their
exactly, right?
their
They're like,
speakers
"Oh,
right now.
it was this." But then we
We
still
never
did
should have left. I missed
but
that system.
but then we still did orders like on paper. So it was this weird, hybrid thing. And then I was there when we made the switch over to Epic, and that was a huge deal. And
Would you call it epic,
it was it
in
was
fact?
it was an epic. For some people would call it an epic fail that
Uh-oh.
that we but that was we understood, I think, that the reason why we needed it, for all the reasons, just to make things more efficient and, I mean, in some ways more efficient, but just the documentation, more thorough, and you could actually read the handwriting. I mean, you could
Mhm.
read the text. You didn't
Right.
have to try to read doctor handwriting. But it was a huge challenge for a lot of the physicians, and there was a lot of stress around the go live and switching over to that kind of system. And so, I feel like we're at the point now, though, where everybody accepts that that's the best way to do things. But we also now have all these different systems that still don't seem to talk to each other and in a lot of ways. And that seems like a big struggle right now, as opposed to like actually getting people on board with electronic health records. Am I wrong in like seeing like that's still like a big problem that we have in this whole system?
No, you're absolutely right. And I think, A part of that is just kind of the nature of adoption. Like we got to get
Hmm.
everyone from paper to electronic first, and then start to think about what are the things that we want to build on top of that. Interoperability being one of them. We want the systems to be able to talk
Right.
to each other, and we want to be able to do things that are more than just like better billing and getting rid of file cabinets, right? I mean, we expect more out of the $35 billion investment
I would say,
that we've made, but I think it's
yeah.
appropriate actually to phase it. We In a prior organization that I worked for, we implemented electronic health records among community
Uh-huh.
docs, and and often ONC and the whole program gets criticized for not doing interoperability from the beginning. I guess I would argue that. That was actually really appropriate to phase it because I still remember one of the physicians who we brought live first. So this is back in 2005, right, really early,
Hmm.
and we brought him live, his practice live. It was a him, brought him live on his EHR, and we had a lab interface set up with the hospital. And we turned it on. And I wanted to be there for the ta-da moment to see the joy that would spread across his face, right? And the and the laugh started coming in, and it wasn't joy; it was terror. It was like, "Stop it! Stop! Turn this
Oh
off
no.
now! What is this?" And I was like, "No, no, no! Those are the labs that you can." It's like, "I don't want them. I'm not responsible. How can I be responsible for all those? Where are those coming from?" It's like, "No, no, those are the same labs that you ordered. They're just not coming in via fax. They're coming in electronically."
Right.
But he was just like, "Turn it off now." It's like I'm
Yeah.
having enough problems just dealing with the EHR that I document. Now you're bringing in all this other information. So I think part of it is just that cultural thing that you first got to get people settled.
Hmm. Right.
Second is one early learning we had in implementing EHRs with all these docs is if you screw up, they're getting paid, then
Yeah.
everything else
Yeah.
stops, right? And everyone's always criticizing, oh, you just focused on revenue cycle. It's like, well, people need to get paid. Like the minute that the revenue
Right.
cycle broke and all of a sudden cash flow stopped coming for 2, 3, 4 days, the practice is like, all right, we're done here. Thank you
Right.
so much for coming. Take all your computers and and we'll see you next decade. But we need to get paid. So that was the other thing is you got to focus on
Gotcha.
landing safe is kind of how I think of it. It's like let's land everyone
Okay.
safe first, and then we can move to the next thing. The last thing on interoperability, I think, is that standards change a lot. Like if we had because we were through this federal program, you were starting to implement EHRs like in 2012, like 2011, 2012, and think about what technology was like back then. And we would basically have been like baking in AOL. For all these systems, and now we have much better ways of interoperating. You think about the apps on your phone and all of that. That's like RESTful APIs and all this technical mumbo jumbo,
Uh-huh.
but a lot better standards now that are much more lightweight. And that's what we're trying to push the industry toward is those lightweight standards. So it made sense to wait because that things are going to change. And if we don't have to make those decisions that early, let's not make those decisions until later and let, all the other parts of the technology develop.
Are we still in the early stages of the achieving the
Oh yeah, that's what I was gonna
interoperability?
ask.
Or are we like
Yeah.
where on the spectrum are we here? Are we anywhere
What
close to
phase are we in?
um, I would say, we're not infants. I think we're toddlers.
Okay.
And the reason I say that is
we
there.
throw temper
And we're
tantrums
breaking a lot
Right,
of
and
right.
we
things.
Well,
break a
yeah,
lot
we
of
throw
Yeah.
temper
rules and
tantrums appropriately, but there is interoperability that's happening. So there are networks now that
Mhm.
exist that connect up EHR systems, and there's one called Care Quality that exchanges like they do 50 million transactions a day. Um,
Okay.
Connecting
Like,
up
yep.
provider organizations on the back end, and just to give you a sense, the Swift global banking network does 41 million a day. So that's a lot of
That's a
interoperability
lot.
that's happening. The
Mhm.
problems with it are the data is still highly variable in terms of quality. So you may get, like if it's coming from a different EHR system, for example, you may
Mhm.
get it and it's still like, that it didn't come together seamlessly. I'm having to
Mhm.
go into this other tab and find it in the basement of the EHR, and and it's hard for me to read. And I really just wanted to know if the patient was allergic to penicillin or something, and I have to read through an 80-page electronic document to figure that out. Ugh, it's a lot easier to
Right.
just pick up the phone and and
Right.
call. So I think we have those challenges that now we are better and better at delivering the information back and forth. More work to do for sure, but
Uh-huh.
better and better at that. But the next level is, well, how do we make sure that the data is actually useful, and that it's giving
Right.
you the right information at the right time so that you can actually, make better use of that information, and get through your day in more efficient ways than you're able to today. That's sort of the next set of challenges that
Mhm.
we want to,
And are we looking at, like, standardization as a part of that to, make the data systems from each place be able to be more, easily compared with each other and merged together? Or is
yeah.
maybe AI something that can help with not having to do that as much? Or what does that look like exactly?
God, we're only a few minutes in and AI came up
Yeah.
Oh,
already. Yeah.
man. Absolutely.
I knew we were going to get there. Standards are certainly a part of it, because,
Mhm.
Yeah.
that is a challenge, and computers are, really dumb in certain ways, right? Well,
Right.
before AI, computers were really, really dumb, right? So they, if that lab came in, and here, in your lab, it's, sort of a blood panel in that hospital, and this,
Mhm.
it's a CBC or something. The computer's like, oh, those are two different things. I have no idea what that is. And so if the data isn't standardized, it makes it really hard for you to be able to get it integrated in the right way and do all the great higher level things you want to be able to do with it.
Right.
The hope is that with AI, you have the ability to say, we can actually learn and see that those four or five different things, or the things, those different lab results that the computer thought were four or five different lab results, are actually the
Oh,
same
yeah.
lab that was being done. It just happened to be done by
Right.
different labs. So a better ability to make sense of that information, to turn data into information, I think, is what we want to be able to do.
Yeah.
That would make a lot of sense, especially with how many different electronic health record systems there are out
Right.
there, that display things in different ways and
Yeah,
different
and it's even
organization.
deeper, I would argue. And you can tell me, you're being a clinician. I'm just a fake
Yeah.
doctor. I'm one of those PhD doctors, but you're like a real doctor. Is that I think it goes even, it's deeper than the EHR. It's that providers, doctors themselves,
Mm,
document differently, and they want to
Right.
document differently.
right.
So I often hear, how come you didn't require that the EHR vendor do this or this? And I was like, well, the minute I did that is the minute that you would tell us that we were, socializing medicine, because we were forcing you into that template that came from Cerner or eClinicalWorks.
Right. Yeah,
And is
yeah.
that what you want? And I've helped doctors implement EHRs, and the first thing they do is they tell the software vendor, you need to adjust the software to my way of documenting,
Yeah.
because
Yeah.
I document better than all those other guys and gals.
Actually,
uh,
you got it pretty nailed. The
yeah, yeah.
the
Especially in
the
your
the
case, I know that
the
you
physician
document better than.
mindset. Or my scribe documents better
Yeah, let's be honest,
than
he's not documenting anything.
it's funny. The as you've been talking, I keep thinking back to CPRS, the VA health system,
Yep.
which has been around since, I don't know, the 80s, right? It's a long time. And I just it's been a while since I've worked in a VA system, but um that seemed to have the interoperability down pretty remarkably for how old it is, and just being able to pull up all the records on your patient, regardless of which VA they've been to in the country.
Mhm.
And do you feel like we've learned lessons from that? Was that like a stepping off point for any of this, or is that just a completely separate thing that uh, doesn't really inform our thought process on this at all?
I
Like
think
is
it
is
does. I mean, you said, you had a key phrase in there, which was you could bring all the information from the various VAs.
Yeah.
So it's like, they were all using the same software. It was just, sort of different instances of the software, different
Mhm.
databases under the same, kind of basic technology. And so that made it easier for them to be able to bring it together, because it was, basically the same technology. But I think that there were a ton of lessons,
Yeah.
that were learned and continue to be learned from the VA, because it kind of showed what the promise was. It showed that if you could actually get these systems connect with each other, here's kind of a vision of the future of what that can do for more holistic view of the patient, and for better quality. I mean, my
Yeah.
mom. It's funny. My mom was a physician with the VA for like 35 years, and my dad was in private practice. And for a long time there was the kind of, private practice is, higher quality, and that's where, the highest quality. And then the VA started being able to show data that demonstrated that, hey,
Uh-huh.
we got this technology and we actually deliver pretty darn good quality, it turns out. And my
Yeah.
mom was like, wow, you know, look at the VA.
Right?
Who knew the VA actually delivers high quality? So I think that there are a ton of lessons there, and there continue to be tons of lessons. I mean, they're going through growing pains right now as they move to a commercial vendor. But I think one of the challenges that they found
Right.
with the Vista system is, you know, when it's customized, it's really hard to keep up with that. And once you need
Yeah.
to keep growing and building, and if that's all custom development, it ends up, having a lot of overhead and a lot of weight on top.
So just for Kristen's information, the this Vista he's talking about, which is the documentation system at the VA.
Yeah.
Basically, it felt like a glorified Word document. It's
Mhm.
basically kind of like what it seemed like, but you could customize your own documentation pretty well. I honestly, when we moved over to Epic for the first time, I was like happy to go back over to the VA and be able to like it seemed so simple at the time, but there's other issues with that as
Right.
well. But yeah, I mean
Right.
it's
Yeah.
just you go to something like the systems we have now, and there's you can see how it would be very overwhelming to someone to, like, just dropping them into this when they've been on just your paper records and writing. Man, we still in our practice we have some paper charts still that we have, like, they're old now, but
Wait,
we
what?
keep a few. Yes,
Yeah,
no, we
don't
don't
tell him
document on
that.
them.
You're gonna
We
You're
keep
killing
them
me here.
around. I'm sorry. We
They're records.
they're records.
Record
We're gonna,
keeping.
we're gonna
So
be
we
sending
just
the police out to confiscate those.
don't tell it. We're gonna delete this
Yeah, we
episode.
gotta edit all this out.
um, but man, I'm just very occasionally, like if someone's had LASIK or some eye surgery from like 20 years ago, sometimes I'll go back and I'll look at that paper record. The documentation, my God, it's hard to figure out what was going on, and it's like it only made sense to the doctor themselves. And so, and my point about saying this is that it I think I see one of the huge benefits of everything we've been talking about, the interoperability and the way we're documenting now with our electronic health records, is that in the end, I think this is such a great thing for the patients. And I think from the patient perspective, it probably feels chaotic. There's all,
Yes, it does.
right? It does. But in the end, I feel like it's we're moving in the right direction toward just being able to educate our patients a little bit better, having them have access to some of their records just more easily. And I don't know. So could you speak on that a little bit, on how you see where we're going, really improving patient care and
Yeah,
our
like, you know what I would like
relationship
to
with
see is
patients?
I would like to see, and I don't know, sorry to mention AI again, but I feel like it might be helpful for this. Um, he and I both have somewhat complex medical histories, right? So I would like to see the ability, like technology, be able to come in and do pattern recognition, which is what it does so well, right? And be able to say, this patient over their lifetime has had this, and this, and just really quickly and easily be able to tell, oh, they have this, complex condition or whatever that a lot of
Mhm.
human beings would miss. So, that would be delightful from a user perspective. Can I just, like, do you have a suggestion box that I can drop that into? Or,
'Cause you just did.
okay,
Exactly.
good.
I think we're getting there. I think we're really getting there, and we're really, sort of at the cusp of that kind of capability. And what the reason I say that is, um, you need at least two things for that. One is you need the interoperability,
Mhm.
because
Mhm.
Dartmouth Hitchcock, let's say, only knows so much about me, and
Right.
in order to be able to, really in a complete way do what you're describing, you want to be able to have, well, I need as much information as possible before I can,
Right.
sort of turn the algorithm loose, and then be able to, get the most accurate type of, view of you as an entire person. So
Right.
first off, you need interoperability, and that has to be higher quality data. So as we were describing before, if it's interoperability with dirty data, well, great. Now I'm applying my algorithms to raw
Garbage in, garbage
sewage,
out.
and what am I going to
Yeah.
get? Am I going to get potable water out
Right.
of out of my algorithms
Right.
on raw sewage? I don't know. Um, but so that's the first thing, and then the second is the algorithms themselves. How do we
Mm.
bring those to bear in a way that that they're easy to use, that they're understandable, and that they're safe? I mean,
Yeah.
um, I'd love both of your views on this. I mean, we're just at the just at the beginning here of this revolution, with Chat GPT and everything, making these tools really, really easy to use and almost dangerously easy to use because you can just start
Right.
just using them. And and a couple of the challenges with this, I mean, I've heard from providers who get concerned about algorithms because of the black box nature of them. They kind of feel like,
Mhm.
well,
Mhm.
I could take the whatever results are coming out of this, that no one can explain to me where it got those results that said that your risk is high, or I could use my
Right.
clinical judgment, which I actually know something about. So until you can explain to me what the black box does, I'm going to use my clinical judgment. But
Right.
hopefully as those get better and better, we'll have greater comfort with them, but we need some guardrails around them, I think, just so people feel a greater sense of safety as well, because you can make decisions that are dangerous, in certain cases.
Right.
Right.
That's why I kind of, maybe I shouldn't scoff, but I kind of scoff at this whole idea of, replacing people in healthcare with AI. And you get on social media, you see people that are playing around with it and like show how it's not there. It's not even close, really, with being able to replicate the thought process of a healthcare professional taking care of people and
Right. But
and
it passed the
um
MLE.
it
Isn't
it
isn't
Yeah.
but it yeah, because we all know that that's the highest quality evidence
Yes.
exactly.
for someone being a doctor.
Right. It also doesn't get at the fact that, like, it's still people putting the
Right.
data in, and writing the algorithms, and, you can't really completely extricate humans from the technology.
Right.
Yeah.
Right.
So,
Yeah.
I don't
I
know.
think. I mean, I think that's a great point. That that, and it's so early. Like who knows where this is headed. That right now it's kind of, well, is it automation, meaning we'll get rid of doctors, it'll all be computers
Mhm.
doing it, or is it something that is really a part of human assisted
Right.
sort of
Right.
care, right? That
A
that at
tool
some
in a
point,
toolbox.
yeah, and that and I could see a point, where as a patient I may actually want to know, well, I'd love to know that, you as a dermatologist, that you actually used some AI in the background to screen through, 2 million patients before making a judgment on whether that mole actually is cancerous or not. But, I also would
Mhm.
take
Right.
comfort in the fact that you're making the final decision. So
Right.
there may be a
Right.
little bit of a demand kind of thing too, where patients, want to know actually that you're using the tools that, the people have a sense can actually help you, and
Right.
but also that you're in control and that the human
Mhm.
is is sort of in the loop there. I think the
Mhm.
other thing, getting back to your point about wanting to be able to have sort of what's the dream here, um,
Yeah.
is we're doing a lot to make information available to patients so that patients can have the ability to take an app of their choice, download the records onto their iPhone. We'll talk about some of the concerns with that in a second. But the idea is that you ought to be able to take your records, and maybe it's in 5 different places, take those records in 5 different places, maybe bring in other information that only like your Fitbit information or whatever sleep app you're using or whatever else, and your over the counter, purchase data and your food data. And you can imagine services developing that say, we can take all of that information and
Mhm.
give you, information about your wellness and, advice. And I'm sure nothing will go wrong with any of that, but no,
Yeah, no,
right.
insurance
But that's
companies
that's the
won't abuse
opportunity.
that in any
Right.
way.
But
Right.
that's the opportunity for you to be able to do those things that your healthcare provider isn't going to do, because that's not the way we think of healthcare in the US.
Hmm.
Healthcare is
Right.
in the US is when you get sick, then I show up at the doctor, I show up at the hospital, and they use whatever medical information they have, and that's what they do to make you not sick anymore. Versus a view of, well, wait a minute, we're on this continuous journey of different degrees of, kind of wellness. All of us
Right.
are temporarily healthy at points of our lives.
Yeah.
And your ability to have more and more information that services can develop around and provide you with information that guides you through that entire patient journey. That's kind of what we want to be able to enable.
Mm.
Right. Yeah, and I think patients are always going to look for information and try to figure out their own things, right? They're doing that right now with Google. I mean, you can't just like take that out of the equation because that's not human nature. Humans are going to be curious about this thing that's causing them a problem, and they're going to do what they can do to figure that out. So, building technology that enables them to do that in accurate and safe ways instead of who knows what ways that lead to who knows what misinformation,
Well,
I think would
I
be
think that's
beneficial.
yeah, and I think that's one of the challenges is that a lot of medical information can be dangerous without context, right? And that's why you talk with your doctor about your health issues and so I know there's been a lot of conversation lately in the past year or so about having your medical tests and results available to you immediately, right, as soon as it's coming in.
You're welcome.
And that's you? Did you do that?
I know this is controversial, but I am a big fan of that, so thank you.
Thank you.
No, and no, and I think it's interesting to hear different perspectives on it because there are a lot of people I know, a lot of physicians who feel like this is a dangerous thing, and that without the right context, it can lead to a lot of anxiety, a lot of other issues.
But maybe the technology can help provide some of that context,
Right, right,
that's
and
what's
that's
missing.
yeah, exactly. That's where I was going next. Is that I think that the solution isn't to just not do it because
Right.
that's not right.
It's patronizing
Right,
too to think that
exactly.
people
Like
can't handle their own information.
people should. It's their information. It's their
Mhm.
own body. It's the things happening inside their own body, and so they need to have that information. But we have to just be able to also give that other context, or be able to let them not set them up to to not understand what they're seeing.
Yep.
Right? I don't know how to make that happen. Can you fix
Yeah.
that?
Yeah,
Can you
you know,
do that
Add
too?
that to the box.
we're working on some of these things. So so the
Come on, Mickey, let's go. Come on.
what's taken so long? I think we're in this weird transition on that, which is
Mhm.
we're not going to be able to sort of engineer all the perfect solution before doing it. I mean, my experience is it's not until you actually do it that people start to realize, oh, wait a minute, we need to have some more context around some of this stuff. Like, as you're pointing out, better education to patients and have that push to them. But until we said, you need to make the results available, that's when people start paying attention and saying,
Right.
oh, okay, yeah, we need to be able to do that. And right now it's really kludgy. And my daughter is a physician, and she talks about situations in the hospital
Mhm.
where she's a pediatrician, where they will literally race down to the waiting room to make sure that they're able to talk to the patient before the patient's parents before something
Mhm.
shows up on the app, that they want to make sure that the
Oh,
patients,
wow, yeah,
the
yeah.
parents have an understanding. So right now it's all like manual, and we're trying to sort of figure it out a little bit ad hoc. But the idea is that the technologies will rapidly develop to provide context,
Mm.
as well as provide capabilities that are more calibrated to individual patient preferences, because I think that there's a whole
Mm.
spectrum that the current system
Yeah.
just never really sort of addressed. Which is, and what I mean by that is, the current system was every hospital physician made kind of arbitrary decisions about, well, we're going to wait a week before giving you these results, we're going to wait a week and a half. And that meant that all the people who actually really wanted the information right away were just left out. You had no choice, you couldn't
Right.
get it. And what we're the reason to do it the other way is to say, you know what, we should make it available. But if if there are patients who say, I would rather you wait a week, then by all means, our regulations say that's totally fine. Now, the technology hasn't totally caught up. Some vendors have developed that capability to allow you as a patient
Mhm.
to literally come into the portal, say, I would like to wait a week before any results, or I'd like to wait before, wait for my provider to call me first. And what we need is for the supply side to kind of now meet that demand. Um,
Mhm.
but otherwise, I think it just wouldn't happen unless we,
Right.
sort of said, you know what, let's make the results available to, to everyone, and then let's have everyone adjust to that. And we
Yeah.
also don't think
I think
about
that's a
the other
smart way.
side of it. For every one of those anxiety-ridden, sort of situations where someone got the result before they were able to talk to the provider. I mean, I've people on my staff. One our head of policy who wrote a blog about this. So I'm not sharing anything that she wouldn't feel comfortable sharing. Where she found out she got breast cancer on the portal, and she felt like that was actually a positive experience because she could collect her
Mhm.
Mm.
emotions, she could do a bunch of Google searching, she could talk to friends who were physicians, so that by the time she talked to her physician, she felt much more poised and better prepared to actually have, the conversation she wanted to have.
Yeah,
Right.
that's a
So,
good
That's
right?
where
good
I fall
perspective.
on it, which
Yeah.
is why I'm a fan of having access to that information is I don't know, I wanna be able to do just that, get my head wrapped around it. Otherwise, you go into or at least do, go into the doctor's office, and they give you this information, and then you're just kind of, like, in shock, and you don't hear anything else that they say for the rest of the appointment, and, I don't know, I
And
think it's
Yeah,
a good thing.
I totally agree.
it's hard for physicians to put ourselves in that mindset because we know too much about medicine. Like we know all these things. So it's hard for us to think, okay, from even when a physician's been a patient,
Mhm.
like it's hard to think, okay, what if I didn't have any medical background knowledge whatsoever? Like what would I want here? And because a lot of it's just being able to empathize with other people, but it's hard to do
Yeah.
that when we already have the information.
And we remember how anxiety provoking those days are in between,
Yeah.
the waiting days of I noticed something and I have to wait for my appointment to see whether it's anything harmful or I got this test, but I have to wait for days or a week to get the results. And those waiting days are just
Yeah.
Right.
excruciating.
Yep.
What I do know is that I don't think people should have to wait just because their doctor's an ophthalmologist who doesn't work on the weekends. Like, come on. Like,
we'll
let's
we'll
get
work
with
on
the
that as
times
an
here.
exception to the rule. That's a
Yeah.
legitimate exception. Right. Another really interesting point that and this is just, a function of our medical system, which, as we know, isn't as responsive to patients as we'd like it to be. There's a patient advocate who we worked with who points out that, for all the conversation about the trauma of a patient getting a result before they talk to the provider, think about the financial side. Like, our healthcare system has no problem delivering, a 17,000 surprise bill to a patient. And
Mhm.
thinking about, what kind of trauma does that count? Does that
Yeah.
cause, right?
Right.
I would argue that in a lot of cases, that's a lot more trauma that's imposing on
Yeah.
individuals than
Oh yeah.
than their
And
test
what kind of
results.
trauma does it cause to not know when you want to know?
Right.
That is like
Yeah.
what I was just
Yep.
getting at. I
Yep.
mean,
Exactly.
it's
No,
tricky.
you're right. You're right. I mean, you don't have to tell me twice. Yeah, the insurance company is causing more trauma than anything on earth. So, yeah, for the most part, might be a bit of an exaggeration, but anyway. All
Anyway.
right. Well,
Anyway.
let's take a little bit. Let's take a little break, and
Let
we'll.
you cool off for a second.
You mentioned health insurance. All right. Yeah. Let's take a little break, and we'll be right back with Micky Tripathi. Hey, Kristen, have I ever told you about Demodex?
I'm afraid.
The little eyelid
Oh
mites.
gosh, no, don't do that.
I'm just saying, if you've ever had red, itchy, irritated eyes, it could be Demodex blepharitis.
You might have some little friends on your
They're not
eyelids.
quite this big.
Well, that's comforting.
To find out more, though, you can go to eyelidcheck.com. That's EYELID check.com to find out more information about Demodex blepharitis.
Don't freak out.
Get checked out. All right, we are back with Dr. Micky Tripathi, and I want to just have you talk a little bit about your own background because we've talked a lot about your experience, the awesome things that you're doing in IT, most of which I probably don't understand, and I never will be able to understand them. But you have this isn't your first foray into the medical world. I understand your parents were both physicians. Is that right?
Yep.
And you had a couple interesting jobs growing up in the medical world.
Yeah, I did. So I was an orderly, as we called them back then. Do they still use that
You
term,
don't hear
orderly?
that word anymore.
No.
I don't even
Yeah.
honestly. What exactly? I think of an orderly as like in the movies where like you have someone pushing a bed around. Like that
Yeah.
was like
Like
kind
that
of an
you take
orderly, right?
orders. Like, hey,
Yeah.
you,
The person, I
orderly.
guess, from a
I never
from
even
a
made that connection.
literal standpoint.
I am ordering, and you are the orderly.
Yeah,
Oh my
I'm the
God, maybe that's
orderer and
it.
the orderly.
exactly.
That must be it.
Well, I was definitely
Man.
taking orders. I mean, that's
All
for
right.
sure.
So you
You're
So
the
worked
one
yeah,
as
doing
an
the grunt
orderly.
work.
Yeah.
Yeah, it was kind of the equivalent of like the nurse's aide, right? You're one step up from the volunteer, like nurse's aide. I don't even know if they use that term anymore, but it was sort of the male equivalent of a nurse's aide.
Yeah.
I wore all white, um,
Gotcha.
and so I worked summers as an orderly in the community hospital, a job that I'm sure I never would have gotten without my father's having had lots of connections with the hospital, but amazingly I was like 16 and 17 years old when I was doing this.
Mhm.
They had us doing stuff that, that I don't think they allow orderlies to do today. Like I was doing Foley catheters on
Oh,
men. For
wow.
those who don't know what a Foley catheter is, it's, when well, I'll let the
It's
doctor
a
explain it.
yeah.
Yeah.
It's a you get a tube up your urethra up into the bladder. So and
Right.
it's, you know,
That's the
it's a
medical
good
way of
long
saying
tube.
it. Yep.
So you
so
were doing that as a 17-year-old? You were
So as a
like
17-year-old, I was doing
okay.
that. I was doing, the
Oof.
pre-surgical enemas, waking someone up at 4 in the morning and saying,
Hmm.
good morning.
Oh,
Here,
wow.
Here's your enema.
here for
Have
your
you ever
enema.
considered that your whoever it was that was supervising you just really did not like you?
That's fun. Now that I think about it,
Maybe,
that's what was
maybe.
going on. um, yeah, so we were doing that. So I was doing that, and then I also was I was in charge of morgue duty. Well, not in charge of, but I did morgue duty. That's what the orderlies would do. Is if someone
Oh,
died,
man.
we were responsible for going up to the patient's room. Um, wrapping them up.
Mhm.
Obviously being as respectful as we could with the process, but wrapping them up and putting them on the gurney and bringing them down to the morgue, and that was fine during the day. But one summer
Oh.
I did the graveyard shift. And it
Uh-huh.
turns out there's only one orderly in the hospital in the graveyard shift, and we would hang around the ER all day. But then, a
Uh,
call would come for morgue duty, and that would mean that I would have to go and deal with that. Um, and that wasn't fun because maybe you can tell me, why are all morgues in the basement? Like,
Yeah,
because
why
that
do
turned
they
out to be
have
a
to
really
be
scary,
as
traumatizing
spooky as
experience for me.
possible?
yeah,
Yeah.
because probably I'm sure it's dark down there
Right.
and this
Yeah,
and
there's no
you're
windows,
No
surrounded
windows
maybe.
and
by
pipes clanking, and
Yeah.
probably
you're
easier to keep
surrounded
it
by cadavers
cool.
and that's
Right.
probably it. It's probably because it's below ground and
Right.
so you get to save a little bit on refrigeration. I
Yeah.
guess I don't
Yeah.
know.
Yeah. Yeah.
But
So
did those experiences they didn't make you want to
Run,
be a
hide,
run and
not
doctor,
be a
hide
doctor.
was,
be a physician?
yeah, so we had this whole thing where, of course, that it turns out that a lot of the morgue duty calls were in the cancer wing, which was a different building from where the ER
Mm,
was. And so when you get the morgue call, and I was in the ER, I'd have to go down to the basement, go through the tunnels, which were, as you can imagine, from a 1920s
yeah.
era community hospital,
Oh boy.
dim incandescent lights
Yeah.
placed,
God.
at about one third of the frequency that you would expect, and clanking pipes because it's
Cobwebs,
all steam going
skeletons.
through. Yeah, and so you
Yeah.
have to go into the morgue, and you have to get the gurney. So it's like going in and like getting the gurney, and then racing over to the to that cancer wing, and then you have to bring it back. And they always told us, go in and you walk it all the way in, and there'll be other gurneys with bodies there, and you put it in order, next to that. And there were like two doors you had to go in. So you open the first door, and then of course
Yeah.
there was like a vestibule, and then in order to get to the second door you have to go all the way in, and that means the first door is closing behind you, right? So
Oh,
yeah. So I'd go
I'm
in with
getting
So
hives just hearing this.
you go
Kristen's
Ugh.
with the body and like
claustrophobia.
open the first door, and this is it's the middle of the night, so there's no one there, like you're the only one there. Open the door, kind of go in, and I am very embarrassed to admit it, but I will admit it here on this public show that I would open the second door and I would hear that first door click, and my heart would start creeping up through my throat, and I would just gently wish the patient well and push the gurney in and turn around and race
Just
out that door,
book it
sprinting
out.
as fast as my 17-year-old legs could take me. It was a pretty scary experience. I am,
Oh,
to this
Oh,
day, I mean, I
man.
didn't see it, but every single time I just had this vision in my mind of one of them like sitting up
yeah.
as I was
Oh,
going, and I did not want to see that if that was going to happen.
yeah. Oh my gosh.
Pathology was not in your
No,
future, I
No.
think.
definitely not.
That's
Or being a mortician. Yeah, that wouldn't have worked either.
Yeah.
Yeah.
and I imagine you weren't, doing any documentation in an electronic health record at that point.
No, the
No.
orderlies didn't do any documentation of anything. I mean, I assume someone
There's no
documented
record
that
of you even be there. No, no.
patient had a Foley catheter put in, but no one ever asked me to document anything. So,
And how are your Foley, inserting skills these
ooh,
days? Do you think you could
I'm out of practice. Let's just
yeah.
say, yeah.
Thankfully so.
Oh,
Thankfully
man.
so. Yeah, yeah.
Did your
Well,
because I know your father was a surgeon, general surgeon, is that right?
he was, back then. I don't think people do this now, but he was both a family doc and a
Mhm.
general surgeon. So he was like
Hmm.
the old
Oh,
Marcus
okay.
Welby type doc. So he was, he had a solo practice his whole
Mhm.
career, and he would, see all generations of the family. But then when you needed your appendix taken out, he would
He
refer
was
you
the
to the
one.
hospital. He would go into the hospital. He'd do the surgery. He would do rounds every day. He would do house calls. I mean, he did, kind of the whole thing.
That's the
Wow.
classic, like, yeah,
Yeah. House call doctor.
everythingologist. You just kinda took
He
care
did,
of
yeah. I think,
I mean,
probably
I feel
doing
like it's got its I'm sure it was difficult as well, but I feel like it's got some pros that we're missing these days,
yeah.
of like one person who knows a lot of things about each patient. And this gets back, I guess, to what we were saying before about trying to make the technology catch up to that to be able to kind of pull together all the information over a lifetime. I don't know. I like that aspect of it
Yeah.
anyway.
But not the aspect where those docs were, like, working, like, 120 hours a
Nope.
week,
Mm-mm. Nope. That was no good.
right. I mean, he was on call.
like,
My
24/7,
growing
right?
up, I remember him. I remember many times, watching Red Sox games, watching Bruins games. 9
Gotta
p.m.
go.
Uh-oh, there's dad's call. And,
Yeah.
he'd get up and be like, I'm off to the hospital. We'll see you.
Right. Yeah.
It was a different model, but
But
there was a lot of high touch.
Yeah.
There was a lot of high
Exactly.
touch
That's a good
stuff.
way to put it. Mhm.
yeah.
What he didn't know though, and I'd asked him once I started getting into electronic medical records, and he was surprised too that I was involved in electronic medical
Yeah.
records. He's like, "So what? What's the point of these things? I deliver high quality." And I was like, Dad, I know you do, but so just for example, you see what you have 2,000 patients roughly, probably,
Mhm.
right? And how many of
Yeah.
those are diabetics, and how many of those would you say are well controlled? And it's
Oh,
like, well,
yeah.
statistically, I have no idea, and that was the point, right? For every individual, like he
Right.
could name every individual one and what he's doing with each one, but like as an office and as a practice, he didn't really have a good
Yeah.
population health view because he didn't have the tools to do that. And I
Right.
think that's a part of the point.
Yeah.
That's a
We
really
need to
good point.
find a way to get both, to get
Right.
that high touch personal experience and also to have the kind of bird's eye view that the data can
Yeah,
provide.
the chatbots are going to give you the personal experience that you're
That's the
seeking.
thing, right? That's AI is gonna get us there. You just well, a future where you walk into a room and you just start talking, and then it all gets captured and it's there, and
Or you don't
then
even have to walk into the room. You can just do it through your phone
th there
from your home.
there you go. Practice medicine from your home.
That's right.
Yeah, well, not everybody.
There,
It's hard to
yeah,
do surgery.
there's
It's hard
some
to do
things you might
surgery in
want
that
to actually
situation.
be seen in person, but
Like, every now and
Like
then.
ophthalmology. That didn't work very well
Oh, man,
remotely during the pandemic.
Mickey, oh,
wait a minute,
I still have
why
I
can't
still
you
have
just like
nightmares.
look in
Yeah.
my
You
eye?
just
Isn't that enough?
Yeah, I still have nightmares of trying to do, like, on the fly at the height of the pandemic when everything was shut down, trying to do, a teleophthalmology.
Mhm.
It works better for certain specialties than
Also,
others.
these patients are patients who have difficulty seeing
They have difficulty seeing
that's that's a very good
by
point.
definition.
yes, and so giving them instructions on how to, go to a website
Right.
and
Operate
put
yeah.
a little password code
Yeah,
in there.
yeah,
Yeah,
yeah, right.
it had its
It's challenging.
challenges. So,
Right. Yeah.
all right. Well, I have so Mickey. Sometimes what we'll do is I'll have like a just like an elaborate game or something to play. But honestly, I just have one question for you. One question that I think is probably on the minds of all of the medical professionals who are listening to this episode right now. Is there anything that will actually kill the fax machine? Or is this just an immortal being?
It's the cockroach of the technology world.
Are we like 200 years from now? Will we still be
We'll
using
still be
let's
faxing.
can we just like spend a few minutes here talking about the fax machine and how it's still a thing right now?
Yeah. I think the
Tell me your
analogy to the
thoughts about the
cockroach is probably
fax.
a really good one. There is certain beauty in the fax machine. It's very, very flexible, right? You can scribble anything and just send it. It doesn't care about standards or anything like that, you know. But Yeah, I think that is an ongoing source of frustration. There have been,
Yeah.
you know, I think one of my predecessors had a kill the fax or axe the fax. I
Facts.
think it was like CMS had, sort of a thing on axe the fax, and we've been, talking about
Right.
that for years. When I was working in Indianapolis, and we launched this health information exchange network across the city to deliver lab results to all the docs, um, via like a portal. And one of the things we ended up having to do was, I ended up, going to all the different hospital CEOs and saying, the only way for this to work is for you to literally tell all the docs you're not going to fax them their lab results anymore. Like you just have to shut it off. And we had to have all of them agree because there were so many docs who still wanted to get the faxes, right? It's like, well, you're never going to move them off of that unless all of you agree, because you're all competing with each other as well. It's like,
Right.
well, we have to get everyone to agree to shut off the faxes, and that's the only way that we can move forward. But obviously, it's a big country. It's really hard to like
Yeah.
But
turn off all the
yeah.
faxes. I think funny, my daughter is she's a third year resident,
Hmm.
and she's been in multiple systems with like Epic and Cerner, and I was asking her how that's going, and she's like, those are fine. She's like, they're not,
Yeah.
she's like, it's all the older docs who have a problem. She's like,
Right.
Epic, Cerner, I don't care. The training is fine, the systems work fine. The thing that she couldn't figure out was one day they told her, fax this to a community doc,
Yeah.
and she was like literally like, what exactly
Yeah.
do you mean by that? It's like, oh, take this paper and shove it into that machine. It's like, you got to be kidding me. Someone
Well,
needs to show me how to use that thing.
the explanations that I've been given about why the fax is still around is because it's safe. People say it's HIPAA compliant,
Which I
right?
take issue with.
Because you have something that's just printing to some
Yeah.
random place,
How is
and
that any
who's monitoring
safer?
it?
Right.
Who's going to see
It's
it?
actually,
Right.
yeah, in many, many ways, it's not safer. I mean, you think about it, you don't know what's happening on the other end, right? All of us have been
Exactly.
in, I mean, most places are pretty good, but all of us have been in places where the fax is just left on the machine,
Right.
or,
Yeah.
right, lots of stories of people of literally like there was a story a few years ago of a bank
Mhm.
talking about how they were getting patient records.
Oh,
And they,
no.
and they kept
Oh, I
calling the
did hear.
hospital saying,
Oh my
"Stop
god.
faxing these to us."
Yeah.
And it took them like a while to get the hospital to
Yeah.
stop faxing patient records to them.
Oh, wow.
That was obviously a HIPAA
Right.
breach eventually, but yeah, I mean there are
Yeah.
all sorts of, and there's no traceability, right?
Right?
Right.
So you can't go back and do a good audit log. And there are lots of reasons that to be able to argue that
But
faxes are not as secure as electronic information.
Right.
I think it's like cultural change. They're
yeah.
too easy still, and
Yeah.
I think that the job is on all of us to make the alternative easy enough that people will naturally gravitate to it. I mean, my
Right.
mom she had she broke her hip last summer, and we had to bring her from one hospital to the rehab hospital. And they're both on really good EHR systems. I won't name the brands,
Mhm.
and I know they're connected in the back end. Remember that 50 million transactions a day I was
Right.
telling you
Mhm.
about? Well, those two hospitals are definitely connected on the back end. And yet, when we're about to transfer her, they printed out her record and handed it to me, and they're like, bring it to the other place and they will upload it. And I'm looking at them like, you guys are doing this right in front of me, like without shame. Because I have no time right now. I'm dealing with my mother. But I think
Yes.
that's part of the problem, is that the
Yeah.
systems are actually getting connected on the back end, but the frontline users are
Mhm.
kind of victims in this, right? The frontline
Right.
doc, the frontline registration person, they're not, that no one is coming to them and training them and saying, you know
Right.
what, we have all these systems that are here to make your life easier. Because when I was describing to them, you realize your systems are connected electronically, and they're like, that would be awesome. When is that coming? It's like,
Oh, no.
it's here. No one has told you this deep dark secret that lives in
Right.
the basement of the hospital.
Oh my goodness.
It's
Well,
happening
and you all
already.
still use pagers too, like 1980s
Well,
beepers.
we gotta
Like,
have some way to be able to have work find us at any moment. Cell phones, yeah, well, but again, like, you gotta, safety and what
right.
I don't know, that like,
Right,
that
right,
I
right.
feel like the HIPAA,
I don't
that
know.
all
I
gets
think that
thrown
gets used
out
as an excuse more than an
to
actual
change, yeah.
reason. Yeah.
I
I
think that's
told
probably
I
right.
think it's a solvable problem.
there's
Someone
something to
told me,
that.
as my daughter, who I trust, she's like, there are parts of the hospital that there is no cell phone coverage. Like you're
Right.
way down in the
Yeah.
bowels of the hospital, down in the
In
surgical
the
center or
morgue.
A
something.
pager will still
Yeah,
get
Yeah.
you.
and the pager works. So
Things indestructible.
I'll
It's like
take that at face value. I'm not going to question her.
it's like the
Yeah.
fax, pagers and
Like the
fax,
Yes.
the
I like the fax. So
the cockroaches and
pagers and
Twinkies.
faxes 30 years from
Twinkies.
now.
Yeah. McDonald's French
And
fries under the
and
seat.
I mean, there's some places that also like when radiologic imaging as well is another thing, right? Like there are some places they'll still like they'll ask for the disc,
The
the
disc.
Oh,
physical
wow.
the physical
That's
disc of your images,
Yeah.
and then you take it to an office, and
They don't have a
they don't
disc
even have
player.
a way to put it into any of their machines because like
totally. Yep.
so that's
Right.
another
I mean,
one
I
of
don't
those
have, I'm just looking
anachronistic
around here.
things.
If someone gave me a CD, I don't
What
really
would
know
you
what
do
I
with
would do
it?
with it.
Yeah.
It's like,
I know.
Yeah.
I don't really know what I do with it. Someone showed me the other day, they got a CD, right? So they wanted it sent electronically, right? And they were frustrated. And then the provider, finally it's like, all right, fine, give me the darn CD. I'll figure out what to do with it. They got a CD, and on it, it said, for provider use only.
Oh my gosh.
It's like,
Yeah.
come on. This is patient empowerment in
Right.
the in the 21st century, right?
Yeah.
So,
Yeah.
so what I'm hearing though is that we have all the technology, everything we need to get rid of these archaic systems. It's more just about making sure that information gets permeates through the entire
You need
healthcare
some
It
system.
change
is.
management
And
help.
Yeah.
there's change management. There's, and while we try to be judicious about regulation, there are just some things, like back to my Indiana example, which was, one city and a lot of work convincing
Hmm.
all the CEOs to do this one thing. There are certain times when regulation at some point just says, you know what, we need to give everyone a little bit of a kick in the pants and just say you
Right.
need to move to the next
Rip
level
the
here.
band-aid off.
Right.
So our regulations, we have a set of regulations that are called information blocking regulations, and it comes
Hmm.
from the 21st Century Cures Act of 2016, which basically said that patients should have electronic access to all of their information, and basically telling the healthcare industry we need to sort of enter the internet age finally, as it relates to exchange information, particularly with patients but with others as well, provider to provider, and all of that. So we should start to see more of a change as that
Right.
really starts to kick in here, that that
Well, good.
hospitals and other settings start to realize, all right, we have to make everything electronic that we can in order to to meet the requirements of this rule. It doesn't happen overnight because these systems are really complex and some of them are really old.
Mhm.
But hopefully, I think that's directionally is really starting to take place now.
Well,
Do
That
you
was the same set of regulations that did the immediate lab results thing.
hmm.
Yeah. Do
Hmm.
you see other disciplines coming in and being useful in this? Because as you're talking, I'm thinking, what I would do as a patient if I have all of my electronic records, if I had the technical know-how, I just feed that into AI myself and see what it says, right? Like that's just
Right.
people are curious about their
Yep.
health. So that's what they're going to do.
That's what we want.
Yeah.
I mean, that's the ecosystem that we want to create, which is giving providers and patients the opportunity to say, you know what, I can the friction of data sharing is no longer the problem. I can get the data that I need, and
Hmm.
now a whole innovation economy can develop on top of that to allow you as a patient, for example, to do just what you're
Right.
talking about and have services that are customized to your need. You can imagine a whole bunch of niche services developing of,
Yeah.
oh, you have Crohn's disease, or oh, you have diabetes, and here's all the information that you have, and we can
Hmm.
provide this service to you and give you reminders and texts and all of that. I think the one challenge we haven't talked about, which is it's a real issue in this country, is that we don't have strong privacy protections
Mhm.
on that data once it leaves the
Right.
confines of HIPAA. And
Right.
and HIPAA has been called, and I agree with this, the most important and most misunderstood law in the world.
Yeah.
That's both important and misunderstood. And
Yeah.
then people, we
Yeah.
saw during the vaccine politics of
Right.
people, sort of saying that's a HIPAA violation.
Yeah.
And all those
Right.
times they said it, it was absolutely not a HIPAA violation. Then there are lots of places where it was a HIPAA violation and people didn't even know it was a HIPAA violation.
Right.
But the challenge is with HIPAA is that um, the minute that you download a record onto your device as a patient, assuming it's not like in an app that's provided to you by your provider, like my chart app from Epic or one of
Hmm.
those,
Mhm.
if you just download it onto your device, is the vast majority of people I think don't realize that you have taken full responsibility now for the security and privacy
Oh,
protections on that. And all of us know what we do with apps, right? I mean, I do it too, right? You download an app and right, the user agreements that have 15
Yeah.
pages
yeah.
of,
Right.
fine print, you're just like click, click, click,
Yeah.
click, 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 just get me to the app. And
Right.
literally, if that app says, we're going to take all your data and do whatever the hell we want with it, and we're going to sell it to the highest bidder, okay? And you just click through it, there's actually nothing in the US that's illegal about that.
Right.
And that's
Oh, wow.
that I think that's a big thing that we need to figure out as a society is how to give patients the protections that they need to be able to use that data in ways that that they expect and that they're not surprised by.
Right.
And
Right.
and obviously with some types of healthcare data, one spill could actually have a real impact on your life if it leads to discrimination downstream and employment and all sorts of other things that could happen with the wrong information being shared.
Well,
So I
now
think that's a big concern.
now I'm getting scared.
Yeah. You just remember there is a lot of potential value, but you are responsible. Once
That's
it's on
right.
your phone,
There you go.
you are
Personal
responsible.
responsibility. Well, let's take another break here, and we'll be right back. All right, we are back with with Dr. Micky Tripathi, and we're going to take a look at one of our listeners' medical stories. So we have a story that was sent in by Michael, and let's see, where does it start here? Okay, my partner and I were finishing up paperwork on a call, and we're parked just outside a convenience store. They were I work as I'm struggling here. I work as a paramedic, and we get some wild stories, he says. Okay. So his partner and he, they were finishing up paperwork on a call and were parked just outside a convenience store. They decided to get some ice cream because it was a nice, beautiful summer day. We made a whole 2 steps into the store when we got a call to the mall for a worker who had amputated their finger in an industrial machine. It's probably a fax machine, I would guess.
Yeah.
Our patient was well and in good spirits. The security guards, being diligent first aiders, managed to track down the severed finger and apologetically explained they did not have any ice and instead used popsicles to keep the finger cold. Once we arrived at the hospital, we transferred the patient along with their finger to the nursing staff. Not to be denied in our request for ice cream a second
Oh
time,
no.
we released
I'm
the
afraid.
brightly colored rockets from their protective plastic container and enjoyed them thoroughly.
Oh my
Hey, that's
goodness.
resourceful. You deliver the
It's
finger
true.
and then the
It's a
popsicles
very
that were
sustainable
keeping
option.
exactly, the popsicles that were keeping the finger
Waste
cold.
not, want not.
Exactly. I'm
At
with you.
least they
Is there
were
is there a
in
health
plastic.
ID point to the story here?
I don't think
Nope, not at all. Not
so.
at all. Just a severed finger story. So
Ooh, baby.
just making you feel glad that you ended up in IT and not
Right. Yeah.
taking care of severed
Exactly.
fingers.
Yeah. Well,
Yes.
I
Anyway,
was
thank you for
I
that,
was supposed
Michael.
to be a doctor, but it didn't work out.
Healthcare
But
Didn't work
adjacent.
out. Is
yeah,
your
Yeah.
da- is your
healthcare adjacent. Right.
were your
Exactly.
parents were they pushing you? Were they like, "Hey, don't you want to go to
Well,
med
both
school?"
of them are parents, and both of them are immigrants from India. So
Yeah.
it was, you're going to be a doctor,
Yeah.
right?
Right.
What kind of doctor are you going to be?
They didn't
But
specify, so you went a
You
different
did
route.
become a
right,
doctor,
went
in
a different
fact.
right, right,
Yeah.
right, right. Yeah, I mean, to their credit, I think my dad in particular, when I started sort of showing misgivings, he was like, if you yourself don't want it, it won't work anyway. It's too hard.
Yeah.
It's too
Right.
Right.
grueling. You got
That's
to have the
true.
passion.
It
So
was very good life advice.
Well, I think
he
you
was.
ended up right where you're supposed to be. So
Yes.
I like to think
Also,
so.
isn't it rich that you have a PhD and feel like a failure, right? Like, I
Right,
think you
exactly.
did fine for yourself.
Thank you. I appreciate that. I'll let them know.
Well, Mickey, we thank you so much for taking the time to be with us today. Do you have anything that you like our listeners to know about? Anything you're working on? Anything? Any final? Parting
Well,
words.
what are we working on? Everything we're doing is, and I know it's all, sort of steeped in the language of regulations and rules and all of that. Um, I like to think of it as, as the beginning of being able to really use technology in healthcare and information technology in particular.
Hmm.
We've spent 10 years, as we were talking about, laying this digital foundation, and now we can all start saying, well, what is it we want to be able to do with all of this now that everything's
Right.
digital? Or, we still got some paper. I know you've got some paper. We're going to go
A little
find,
bit.
root that out and burn it. But, but now that you've got this digital foundation, you can start to say, you know what, this is all bits and bytes now. And how do we
Hmm.
like try to redraw the map of the way we think about healthcare, to really take advantage of this electronic data? That's why I'm really excited about having, being in this position right now, because I feel like all that hard work is now
Yeah,
behind us, and we can think about all the really cool things we want to do,
that's
for
exciting.
patients, for medical science, for providers, all of that. So I think, just I think for any individuals who are listening, like whether you're a patient or a provider, start banging the doors with your expectations of, hey, wait a minute, this isn't the way it's supposed to work in
Hmm.
internet economy. I'm supposed to get my results every day. I'm supposed to have electronic access. The CD doesn't work for me. Um, and
Yeah,
start
right.
having those expectations that you would have of the hardware store. We should have that of the healthcare delivery system as well.
I completely agree.
Yeah.
Absolutely. Well, thank you so much for being
This has
here.
been this has been so fun, and
Absolutely.
thank you to both of you for all that you do.
Oh
I
yeah.
think
Oh,
you bring a
thanks.
lot of insight and a lot of fun to all of this, and I really appreciate it.
And we'll bring some
Thank
things
you.
too.
Yeah, yeah. I'm a little part of that. Yeah, that's right. All right, Mickey. Take care.
Thank you.
Thanks.
Well, Kristen, did you learn a lot about IT?
I learned a lot about fax machines. Yeah.
Yes.
Hmm.
Yeah. I've been dying to ask him that question.
Yeah.
I was holding that in until the very end.
If even he can't fix that issue,
Well, the thing is, it's fixed. We just got to make people not use them.
yeah.
It's like
So
we're
get
all
on that.
addicted to our fax machines. Like we can't just
Speak
stop
for yourself.
using them. You guys gotta have a fax. This is like a week since I've had a fax. I gotta get a fax.
Got fax withdrawal.
Gotta get a fax. Okay. Anyway, thanks for listening. What are we even talking about? I don't even know. Let us know what you thought of the episode. We'd love to hear from you. You can email us, knockknockhigh@human-content.com. Visit us on all the social media networks, Instagram, Facebook,
TikTok,
YouTube,
LinkedIn,
Twitter, all
all
of
the
them.
things.
You can also hang out with us and our Human Content Podcast family on Instagram and TikTok at Human Content Pods. Thank you to all the wonderful listeners leaving feedback and reviews. If you subscribe and comment on your favorite podcasting app or on YouTube, we can give you a shout out, like Gothic Potato 2. I like that one.
Ooh.
Gothic Potato 2 from YouTube wrote, "Keep up the great work because it was entertaining and super informative." Thank you, Gothic Potato.
You.
Keep sending us all your medical stories. We really love. That's like one of our favorite parts is hearing like all the interesting stories. that
So
come
many
through.
stories out there. Medicine is crazy.
It is a lot going on there. And we also full episodes of this podcast are up on YouTube at D Glaucomflecken every week. We have a Patreon, lots of fun perks, bonus episodes where we react to medical shows and movies, hang out with other members of the Knock Knock High community like us. We're there too. Early ad-free episode access, interactive Q&A live stream events, and a lot more. Patreon.com/Glaucomflecken or go to Glaucomflecken.com. Speaking of Patreon community perks, new member shout out to Patrick S. Patrick S. Thank you for being a patron. And shout out
Patrick the patron.
That's right. Shout
Patron
out,
Patrick.
as always, shout out to the Jonathans out there. Virtual head nod to you all. We have Edward K, Jonathan A, Jonathan F, Caitlin C, K, L, Leah, Lucia C, Marion W, Mark, Mary H, Mr. Granddaddy, Omar Patrick Rossbox, Sharon S, Stephen G, Abby H, Brianna Lee C, Chaver W, and Dr. J. You guys, they're making it hard on me.
Yeah, you're having some
yeah.
trouble reading today.
It's hot in this room.
It's
Our air
really-
conditioner's
it's
not
hot.
working, so
Yeah.
I'm getting a little loopy here.
Yeah.
Patreon roulette. So shout out to one of our members in the emergency medicine
tier.
of Patreon. So we'll do our little drum roll. Eleanor F. Thank you for being a patron. Thanks, Eleanor. And thank you all for listening. We're your hosts, Will and Kristen Flannery, also known as the Glaucomfleckens. Special thanks to our guest, Dr. Micky Tripathi. Our executive producers are Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Our editor and engineer, Jason Portiza. Our music is by Omer Benzfi. You want to say this part?
To learn about Knock Knock Hi's program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, you can go to glaucomflecken.com or reach out to us at knockknockhi at human-content.com with any questions, concerns, or most especially fun medical puns. Knock Knock Hi is a human content production.
Nice job.
Knock knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.